It is just a huge honor for me today to be podcast interviewing a legend in dentistry, Lee Ann Brady, from leeannbrady.com, restorativenation.com, Pankey.org. She is a privately practicing dentist and nationally recognized educator, lecturer, and author with an extensive history in leadership. She is currently director of education at the Pankey Institute. Dr. Brady has also developed a vast library of online instruction at leeannbrady.com and restorativenation.com. She practices in Glendale, Arizona, is a member of the editorial board of the Journal of Cosmetic Dentistry, Inside Dentistry, and Dentaltown Magazine. And seriously, I've been trying to get you on the show for 2 years. Thank you so much for coming on today. You talk a lot about occlusion, materials, restorative, continuing education. I just want to start with this one question. It seems like if you talk to 100 endodontists, they don't really disagree on much. If you talk to 100 pediatric dentists, they don't really disagree on much. Man, when you go into occlusion, it's like 10 different major world religions. Why do you agree with that assessment or not really?
Well, I mean, yeah, experientially, I do agree with that. That for years, historically, occlusion has sort of fallen into camps. And people look at occlusion, think about it, diagnose it, and treat it based on how they were trained, which particular philosophy they were trained in. So yeah, I would agree that's been my experience in 29 years of practicing dentistry.
So these kids coming out of school, I mean, this is July 10th, so last month we had 6,000 new kids join our profession. And how are they supposed to pick a camp? I mean, because one of the common questions is, should I do neuromuscular? Should I do CR? And podcasters are young. I mean, people our age read textbooks. They jam out on their iPhone to podcast. So help talk to these young kids on how they should pick a camp or what they should be thinking about.
Well, one of the things that's interesting about it, Howard, is if you look at the different occlusal philosophies, we actually agree about a whole lot more stuff than we disagree about. So that's the good news, is that, if you actually said where are the areas we agree, it's going to be the lion's share of what everybody is teaching, no matter where you go get that education. And there are some pieces of that puzzle that we don't agree on. And so, one of those, for instance, is kind of where are the condyle disc assemblies when you make all the teeth touch, right? So the three biggies are intercuspal position, which the truth of it is most dentistry gets done by just saying to the patient, bite. So that's maximum intercuspal position. And we don't actually know where the condyle disc assemblies are. And the reality of it is, does it work? Of course it works. That's why, if I took a guess, 85% of all the dentistry in this country gets done at maximum intercuspal position. Of course, the risk is it doesn't always work. So there are those patients on whom that's not going to be a predictable, reproducible, comfortable position. Then you have the folks that want to seat the condyles, and people refer to that as centric relation. Does it work? Absolutely it works. Does it ever not work? Yeah. For some patients, that's not an appropriate approach. And then the third big approach would be neuromuscular and finding something called myocentric. Does it work? Yes, it works. Does it ever not work? Absolutely. It's not for every patient. So for me, one of the things I've done over a lot of years is I actually got education and got continuing education from a variety of different approaches, so that I could look at, here are the things across the border that are consistent. Make all the teeth touch evenly, make the front teeth, make the back teeth come apart. And I could also then interpret the things that are different and realize that it's actually the same as everything else we do in dentistry. It's about diagnosis, understanding your patient's risk factors and what they present with, health of their joints, muscles, and their teeth. What's your restorative treatment plan? And then you're going to use your professional judgment and figure out what's the best approach for that individual patient. So I don't know that I would make a strong, here's a camp to start in from a standpoint of your education. You already have. You did that in dental school. You were taught an approach in dental school. When it comes to occlusion, my feeling about it is just remember it is a part of what we do. So it's not necessarily wise to think you can ignore it, and that if you don't pay attention to it, it won't pay attention to you. It is going to come up in your practice. Keep learning, learn as much about it as you can, and simply remember it's a risk factor your patients present with, just like some people have high caries risk and some people have low. Some people have high perio risk and others low. Some patients have high occlusion or functional risk and others have very low risk. And identifying that risk factor and knowing how to manage it when they show up with it is the key to success when you think about occlusion.
You know, you put 4 courses on Dentaltown. I've seen you lecture many times. You're so gifted at teaching. I mean, you just make the most complex things so easy. I love it when you start making yourself a tooth. You start doing your. Are you aware that you do that? You actually turn into a tooth. You're so good at that stuff. So back to just another one occlusion question. How do you? What advice would you give to keep them out of trouble so they don't, get into trouble taking on one of these? What are the risk factors of someone who's a couple years out of school, where like with orthodontics, you wouldn't want to start with a long face. You know what I mean? You wouldn't want to class 3. How could you keep them out of trouble until they get really grounded?
Honestly, it really is about diagnosis, Howard, and it's like everything in dentistry. If you start working outside your comfort zone, the odds of you getting into trouble are higher. And so it's amazing to me, truthfully, given how much we have to do in dentistry, how much more there is to learn than when you and I went to dental school, that for young people, it's daunting compared to what we had to do. I could talk about restorative materials. I had to learn 2 in dental school, gold and PFM. Today, there's so many, your lab slips like an 8.5 by 11 sheet of paper or a legal size sheet of paper. So, for me, the piece of it is if you stay within what you know and you feel confident, and then you continue to go to education and you start to increase the boundaries of how big that is, then that's really the key to not getting in trouble, whether it's occlusion or restorative dentistry or implants. With occlusion, I will tell you probably one of the newest things that I love that's come up in the last couple years is actually a protocol called the JAMS protocol, which stands for joint and muscle sprain and strain. Really fancy name. I just call it JAMS. And what the JAMS protocol did is it looked at all the different things that we do in a functional exam, and it said, can we come up with a really simple approach for people to assess a patient who has a high risk of developing an occlusal issue, an acute TMD? And they did that. And what they honestly came up with is if you can ask a few simple questions, and then you can do one thing, which is range of motion on maximum opening, you can identify the patients who are your highest risk patients, and those patients do need a more complete functional exam. So whether I was just newly out of school or I've been out of school 15 or 20 years, but I really don't integrate a lot of occlusal diagnosis in my practice, one of the first things I would want to do is learn how to ask these 5 or 6 simple questions, take a range of motion on max opening, and I can at least sort out the high-risk patients before I actually start treating them.
Nice. I didn't mean to turn this into a TMJ lecture, but I would say that if someone comes in and they're complaining of TMJ, grinding, whatever, probably 90% of the time, the dentist's just going to take an upper impression and send it to the lab and make an arch splint for that. What do you agree that's the majority treatment?
Oh, absolutely. I would say that's what most people are comfortable with is we're just going to make a night guard, right? So we're going to take upper and lower alginate impressions and send them to the lab and say, make me a full arch appliance. That's what most of us are taught in dental school. Absolutely.
And what do you think of that approach?
You know what? There is one benefit, which is if you put anything in between the teeth, especially at a new vertical dimension, for about 90 days, you're going to reduce the muscle activity. So you have the chance of a lot of those people feeling more comfortable. The challenge with doing that is if the patient continues to wear it or needs to wear it more than that once they accommodate, if you haven't determined where are the condyle disc assemblies when they're on that appliance, how have you designed the occlusion on that appliance, you have just as good a chance of them now getting worse again or even getting worse than they were before they started than if you'd left them on their teeth. So as an acute, just put something between the teeth. It'll work on a lot of patients, which is why we've taught it for years. I will tell you much quicker than that. I make a patient like that a quick splint, right? And we have tons of those kinds of temporary, throw some bite reg or VPS material inside the appliance. And that can manage that same huge percentage of those acute situations. And if they get better and they don't need to wear it long term, then great, you haven't left them with something that could potentially be harmful. And if they do need to wear something long term, now you have the time to go back and actually figure out what's the best appliance for them to wear based on their joints, muscles, and occlusion.
And what would be the best way, fastest way, easiest way for people to learn that?
Oh, you know what? Honestly, on the internet, which is where everything is, right? So, you know, I can obviously refer people back to the Dentaltown programs that I did for you on occlusal diagnosis. And so going in there and getting some information in an hour online on doing a joint, muscle, and occlusal exam will be powerful. And, you know, I know that you guys have programs on there also about some occlusal appliances. You could just Google Quick Splint. There's others like Best Bite, or obviously folks on Dentaltown are super familiar with NTI. They're all just prefabricated anterior discluder shells that you can just customize to the patient.
Was that the Jim Boyd? Was that right? NTI?
Yeah. Mm-hmm.
Yeah. Yeah. I used to always see him lecturing. I don't see him out much anymore. Did he retire or?
I do not know. I would agree. I don't see his name as much as I used to, but I do not have any of those details.
Yeah. So you have what's the difference between these dentists going to leeannbrady.com versus restorativenation.com? Which one of those websites do they go to for what?
You know what? They're actually both designed to just supply folks with readily available information on the internet. My Lee Ann Brady site is a blog. It's been up for 6.5, 7 years, and it's all in written format. So there's tons and tons of information, 200 to 500 words, so you can get it in like 2 to 3 minutes. Easiest way to use it is the search bar, because there's about 600 articles on there now. So just type in what you're looking for in the search bar, and it'll find you an article. Restorativenation.com is a new website I just launched this year, and it's all video-based. So everything on that website is in a video format, from 2 to 3 minute long video blogs or vlogs, all the way up to hour and a half long, more informative, content-driven videos. So they can go to either. Depends whether they have a preference of reading or watching.
My homies are driving, so I always retweet my guest last tweet so they can find it there. So I'm retweeting the Pankey Institute. Get your infusion of occlusion at our next Essential 2. So I'm going to retweet that. Again, I mean, you are an amazing legend. I mean, how did you write 650 articles? I mean, you are the most prolific content creator. I see you out there lecturing every week. I mean, do you ever sleep?
That actually, I do sleep. But I tell people all the time, I only have 2 states of being on and off. I don't sit on my couch and do nothing much. If I'm awake, I need to be doing something. So, you know, writing blogs and doing that stuff keeps me out of trouble. If I wasn't doing that, Lord knows what trouble I'd get into.
So I'm on your Restorative Nation. I don't see you don't have a separate Twitter for that?
You know what? Restorative Nation is a membership site. So to get in past that front, you actually have to go where there's that join button or members button up in the upper right-hand corner.
Okay. It's true. I mean, what we learned 30 years ago, I mean, I don't think we use any of that stuff. I mean, that was a long time ago. There's so many materials. What's your advice on all these materials? I mean, they go to the Chicago Midwinter meeting, and there was 174 different dental implant companies. I mean, it's just so overwhelming. How could you simplify materials for dentists?
You know, simplifying it for me, honestly, when I think about it, is I want to kind of know what are the active ingredients in a material, and if I know what those do, then somebody comes out with a new dent adhesive or a new this or a new that, I can figure out for myself. Does it do something different than the one I had before? Or nope, it's the same old stuff, just with a different label or different marketing or different packaging. You know, I basically have my philosophy about materials is I only really look at and consider new materials if what I'm using currently isn't working. So if I'm not getting the clinical outcomes I want from my material, I obviously need something new. If what I'm using is working and someone brings me a new material, I want to know, does it do what I'm as well as what I'm currently using? Like, is it equally as good? And if so, it better be easier or less expensive before I'll consider it. Or it better be better than what I'm doing now. So tell me that it's actually going to improve my clinical outcomes. I have manufacturers all the time who bring me new materials and say, we have this hot new this or that. And I ask them those questions. I'm like, is it as good as what I'm doing now and it's faster or less expensive? Or is it better than what I'm doing now? And if so, tell me how. Because otherwise, there's really not a reason for me to move things around clinically. And as you know, in a fast-paced clinical practice, you switch a material and have to learn one new set of directions, that can throw your whole dang day off, right? So there has to be some really good validity to making that decision. And then I will tell you, I go and get information. So I will go to Dentaltown and I'll read what people are saying about those materials. They've already tried it in the mouth. What were their experiences? I'll go to Dental Advisor. I'll go to CR, and I'll actually not only read the scientific report, but I want to read the compare and contrast by the clinicians who've been using it and find out how it's actually working for other people in clinical practice.
It's funny when you said CR. I'm so old, I still think of it as CRA. That was like I can't believe that they were the biggest brand name in dentistry, Coca-Cola, and then they changed their name. I thought that was I thought that was beyond. Another thing, sometimes I fault the dentist for this because sometimes, they're doing a filling and like the best bonding agent might be acid, rinse, adhesive, whatever, but they want it in one step. Remember when they come out with Prompto Pop?
Yep.
Because they just wanted to get rid of a couple of steps, and they're trying to do it with endo files. Well, let's just get it down to one file. It's like, come on, dude, you're doing a root canal. I wouldn't want to be getting a bypass, and some cardiovascular surgeon says, well, I found this new stuff. I can eliminate 3 steps because I'm just lazy. So what do you think some of that stuff is getting too simplified? For instance, like what bonding agent do you use?
So I actually use several different bonding agents in my office because I use different ones depending upon my the clinical situation. So if you said to me, what bonding agent do I use for my day in and day out direct composites, direct restorative? I use a bonding agent called iBond Universal, which is a Kulzer product. If you said to me, what bonding agent do I use when I bond in indirect ceramics? I use Adhes Universal from Ivoclar Vivadent because I'm a strong believer for indirect cementation, that you buy a system and use the entire system from one manufacturer. Because I don't think most of us in clinical practice are smart enough to understand how materials from different manufacturers interact with one another, and are there contraindications or places they're chemically incompatible. So I use lots of them. I do total etch. I'm still a blue gel person because that's how I grew up in dentistry. But I do, that's one of the things I like about the new universal adhesives is that you can do total etch, you can do selective etch, you can do self-etch, hybrid etch. We have all these etching techniques. So you can buy one thing, so you have good inventory control, and you can etch with or without the gel, depending on the clinical situation, without having to have a different product for that. But yeah, I do like blue gel. So, and I've got a system where that's never caused me to have excessive sensitivity or problems in my practice. So I'll continue to use that. I'm a big believer in efficiency, because the truth of it is, in dentistry, time is money. I know we all like to yak about time, is because we think it's impolite to talk about money. But time is money in a dental office. And, figuring out if there's a way that I can do something and I cannot compromise my clinical outcomes, but I can be more efficient, I think about that every day in my dental practice. For me, where I sort of draw the line is I'm not willing to save time if it's going to compromise my clinical outcomes. And that's the hard part as a clinician, is to figure out, when we have newer materials that are fewer steps, is it as good? It just takes less time and fewer steps? or no, is there a compromise in there somewhere that maybe we're not clear about? Self-etching adhesives have gotten so much better over the years we've been using them, decades we've been using them, that when we look at dentin bonding and bonding to cut enamel, they're pretty equivalent to blue gel. We start talking about bonding to uncut enamel, blue gel is still superior. So if you said to me, I'm doing a really conservative veneer case, everything is going to be bonded to enamel, I'd be like, Howard, pick up phosphoric acid and use an adhesive that uses phosphoric acid. Because why not? Why not optimize the outcomes? If you said to me, hey, for my routine class 1 and class 2 direct composites, I'd be like, use a self-etcher if you prefer a self-etcher and you get better clinical results. So, again, for me, it's about information and about understanding what you're using. And if you can say to me, here's why I'm using it, because I believe it's best in this clinical situation, you can answer that question, you have enough information.
And so to be clear, you're saying the bonding agent that you like the company to go from A to Z. So if you're going to use that bonding agent, you want to use their composite. You want to use
not in direct composites.
Pardon?
Not when it comes to direct composites, but when it comes to indirect bonding. So if you're talking about like a light cured resin cement, a dual cured resin cement, I'm putting in a veneer or an inlay or an onlay, and I'm actually bonding it in. I'm a big believer in buy the whole kit. So make sure that the dentin adhesive that you're using came in the kit with the resin cement. I want of incompatibilities.
Okay. I want to ask you another question. Sometimes I almost think that, I just celebrated my dental office 30 years. We opened, I graduated in 87. And it seems like in a lot of respects, dentistry's worse today than it was 30 years ago. 30 years ago, like all my fillings are gold. And, it was all gold and amalgams, and they just lasted longer than all this white stuff. I mean, and a lot of dentists on Dentaltown, you tell them that amalgams last longer than composites. They say, well, maybe yours do, but mine lasts longer. So I want to ask you, what would last longer, your direct composite or a direct amalgam you did in dental school 30 years ago? What do you think lasts longer?
An amalgam. But you and I are compatriots. We're peers. I graduated 1 year after you from dental school. And I guess it depends when you say things are worse. You're obviously referring to the longevity of what we can do. And, there's no question that when we moved from gold to other restorative materials, one of the changes was how long our restorations will stay in the oral environment. When you compare amalgams to composites, there's no question, I think, clinical experience. I could find you research articles that say they last the same amount of time. Clinical experience, dentists will tell you their amalgams lasted longer, but because composites are much more technique sensitive material, and what we just got done talking about time in a dental practice, to do a composite at that level where it's going to competitively stay in the mouth as long as an amalgam, it's going to take you probably 2 or 3 times as much chair time. And so because of that, they're not done that way routinely. And so routinely, our experiences, they don't last as long, okay? But then, of course, if you're going to say, worse or better, we could have the same conversation about using metals versus plastics and people with metal allergies and, and the mercury. We could talk about just the aesthetics of the fact that, as a society, we're way more focused on how things look today than we ever were. And our patients most of the time would not want the dentistry that we did. I could go before you and I, Howard, we could go back to pin retained gold restorations on anterior teeth. And I'm pretty sure when that disappeared from dentistry because patients didn't want gold class 4 angles on their teeth, that the dentists of that generation are like, oh my God, these young people are doing materials that are worse. So part of it is being driven by the demands of our patients and meeting people based on what they want. I will tell you, I still do a whole lot of full gold crowns in my practice.
I bet they're all on men.
You know what? And even some women, but here's one of the demographics. Where I live. I live in Glendale, Arizona. My patient population is all baby boomers. Most of my practice is people my age or older. And so they grew up with a different level of aesthetics in dentistry. And a lot of my patients, because of their age and their life experience, they don't mind a gold crown on a second molar or a first molar. And because of where they are in their lives, they're also, if I say to them, I could do it out of gold and it might be the last time you need a crown on this tooth in your life, or I could do a tooth colored restoration, and I need you to understand we're probably going to replace it every 10, 15 years, maybe 20 if I'm really hitting it out of the park that day, that a lot of my older patients are like, nah, I only want to do it once, But literally today, I put in a gold second molar on a female patient, and I put in a ceramic full coverage crown on a lady patient. They were both second molars. They were probably similar in age. Had those conversations, and one said, I'll do gold, and one said, nah, I want tooth colored. I'll deal with the risks.
Yeah, that is the one thing I grew up with 5 sisters. I can't believe that women decorate every body part they have with gold. Nose rings, ears, belly buttons, ankles, wedding rings. And then you say molar and they look at you like you're crazy. You know how we were talking about, do some of these products, are they catering to too much shortcuts? You'll never meet an endodontist who says, I'm going to do a molar root canal with one file. You're just not going to find that person. What do you think about the bulk fill? Getting rid of the steps. That's another. Is that shortcut keep the same quality, or do you think that the shortcut is a compromise?
Well, you know what? The interesting thing about that is, in some ways, bulk fill composites are an evolution on our traditional composites. So in order to make them bulk fill, the manufacturers have come up with a way to manage the shrinkage stress of the material. They've altered the photo initiators and the direction that the polymerization pulls in. So they're actually superior materials in some way to the generation of composites that came before them. In other ways, it's a compromise. So most of our bulk fill composites, in order to get 4 to 6 millimeters of depth of cure, are less aesthetic. So they're more translucent. They don't look like tooth structure. And so now you have a balance of, if you're doing an occlusal on a second molar, does your patient really care if it's more translucent and lower in value, versus if you were using that material someplace where it was more aesthetically visible. So yeah, I'm of the generation, first of all, when I went from amalgam to composite, I was like, whoa, what are y'all doing, right? We need to use amalgams. And then when I finally got converted to doing posterior composites in my practice, it was, they have to be done in 1 millimeter layers. And I lived through the generations of, ramp cure, arc cure, angled layers, C factor, all this stuff we don't talk about anymore. And so it was like, literally, you never would bulk fill. And all of a sudden they come out with bulk fill. And the manufacturers are sending it to me and saying, we want you to test these products. And I'm like, no way, we don't bulk fill. Bulk fill is a bad thing. But when I finally looked at the science and realized the manufacturers figured out how to make the science better so that bulk filling works, they're actually great products, and you need to know how to use them. Again, it adds confusion. Most of them can't be used as the layer that's in occlusion. They have to have a cap layer because the rates of wear and the longevity in the oral environment of those materials isn't going to be as good. So you need to put a nano category composite, nanofill, nanohybrid, or nanocluster on top of it as a cap layer. But there are a couple bulk fills on the market that don't need a cap layer. There are some that are flowable. There are some that still have to be condensed, either with traditional instruments or a special handpiece. So when you say bulk fill, you kind of almost have to step back and say, what kind of bulk fill are you talking about? Because then we can kind of compare and contrast. But there are a lot of things about that category of composites that are actually improvements over some of the other stuff we've been using.
Are you using one?
I do use a bulk fill composite.
Well, which one?
I actually use Ivoclar's Tetric Bulk Flow composite to do the boxes or the deepest portion of some of my class 2 or class 1 composites.
And you're liking that?
I do like it. I like it a lot for 2 reasons. I love the radio opacity. So one of the places I think we've gotten ourselves in trouble in the last decade in dentistry is resin-based materials that are radiolucent. because I don't think we can evaluate our own restorations on follow-up radiographs. And certainly when our patients end up in somebody else's practice, they have no way to determine, is that a void, an open margin, like what the heck's going on? So their material has really phenomenal radio opacity. It's self-leveling, so it is a flowable, and you can put it in a class 2 box or the base of a restoration. And if you're patient for 15, 20 seconds, it'll actually self-level, so you don't get any voids and you get a nice dense fill. And it does this weird color shifting thing that I don't understand, but it starts out totally translucent, so the light will go through it, and then it becomes more opaque as it light cures. So if you do want to use it someplace where aesthetics is more important, you're not trying to cover up the translucence. But I don't use it as a cap layer. So it has to have something on top of it.
Back to, at our age, we reminisce that, we always think like I still think 99% of all the good songs were written in the 70s. I don't think I've heard one new song since the year 2000 that's even worthy of finishing. And I'm sure that's wrong, because I remember as a little kid, Mom always yelling down the basement, turn that crap off, turn that music down. And it was like the Rolling Stones. But some things I still think are going in the wrong way. For instance, in 1900, there were no specialties. By 2000, there were 58 specialties, and dentistry has 9. And then these kids are coming out of school, and they're saying they want to learn Invisalign and sleep apnea and do their endo and their pulpotomies. And it's like, are we really going back in time where one dentist is going to do everything? And what would you say to, like when a young kid says to me, I'm going to learn sleep apnea, I'm like, that's a lot of information. That's a lot of knowledge. What are you going to give up? And they never are going to give up anything. They just want to learn everything. What advice would you give to some 25-year-old kid that just walked out of dental school that thinks he's going to master implants and bone grafting and sinus lifts and root canals and Invisalign and sleep out? I mean, can you really be a super dentist and do it all?
I guess you can. It depends how many hours of your day you want to devote to continuing education and studying in science and research. I mean, my personal philosophy about it is anything that I do, I want to do as well as anybody else can do it. And so, I've gone and taken classes to learn how to place implants. I don't place them in my practice because I can't keep up with the information at the same level that my oral surgeon and my periodontist can. But I went and took the education because I want to be able to help my patients understand what's going to happen. It helps me figure out who are the right surgeons to work with. I can talk with them. We can have that communication level. I'm a better referral source the more knowledgeable I am. But I don't want to have to maintain the level of information to be an expert at it all the time as it evolves, and it's constantly evolving. But you know what, in the space of restorative dentistry materials, occlusion, the things I love that I really enjoy, I do dedicate the time to stay at the top of my craft. Now, can you stay at the top of your craft in a real wide array in dentistry, wider than mine? My guess is yes, if you have time and the energy and the inclination to stay on top of all of that information. And, what new materials are coming out? What new techniques are people doing? Are you going to the implant meetings and the sleep apnea meetings and the occlusion meetings and the restorative meetings? And, so that's my piece of the puzzle is, if you're going to do it really well. And to do it really well, you have to keep yourself continuously educated in this business. It's changing so fast. It is mind-blowing how fast it is changing. I don't know if you feel this way, but change curve is accelerating. The longer I'm in dentistry, the faster the rate of change is getting, which makes me feel like, okay, it's that much tougher to stay on top of it. And part of it too, I think, has to do with your resources. I know dentists who practice in really rural areas, small towns, where they don't have an endodontist and they don't have a periodontist. And, to try to take care of their patients, they have to get that skill and that level of expertise in all of those areas. And certainly in Phoenix, Arizona, we have lots and lots and lots of access and resources to specialists. And the other thing I would flip on there, Howard, is after 29 years of being a dentist, I'm really clear. There are things in my clinical practice I love to do, and there are things in my clinical practice I do not enjoy. And if I don't enjoy them, I'm not as good at them arbitrarily, and I don't spend as much time learning and staying ahead of the curve. And I also, after 29 years, I don't want to spend my day doing stuff I don't enjoy. I want to come to work every day and be ready to jump out of my car and walk into my practice, not sit in the parking lot having to do yoga meditation to get out of the car. Right? So, and so part of that is realizing, I realized a really long time ago, I don't like endo. I don't enjoy it. It just, I don't enjoy it. I don't enjoy the process. I don't enjoy the fact that often the folks are in pain and uncomfortable before you start. I don't enjoy managing it at a post-op level. So the truth is, I have no idea how they do endo today. You could tell me they do it with one file and I would believe you, because I have zero idea, because I haven't done a root canal in 15 or 20 years, right? But I happen to love occlusion and TMD, so I do a lot of that in my practice, right? I know other GPs who it's the reverse. They're like, I wouldn't treat a TMD patient no matter how much money they were going to pay me. But endo, I love sitting down and doing endo, right? Or how many dentists do you know in the middle? They'll do endo on a central, a really easy premolar, but you get more than one canal, they're out, right? Time to go see the specialist. So, I think it's a blessing and a curse of our profession, right? On the one hand, the blessing is we have tons of choice. We have more choice around how we express our profession than any other profession I can think of. And the other side of that is that sometimes we feel some weird obligation that we have to do all of that, or that we have to be good at all of that, or our patients expect it or something. So I've learned over a lot of years, nope, I actually get to say, and I can still be really successful in my practice, even without doing endo and referring it all to the endodontist. It just makes a whole lot more space in my schedule to do the stuff that I love.
Oh my God. I don't know how the pediatric dentists do it. That is the craziest. I mean, my God, that I'm, that
Hey,
is a,
God bless them.
yeah. And you know what you said, that you went and took the implant surgical courses so you'd be a better referral and you'd see what surgeon on that says. The orthodontists get that the least. When I see the biggest rocking hot orthodontic practices, they set up study clubs. They're like, okay, these guys are gonna get in Invisalign, they're gonna do braces, whatever. But 80% of them will do it for a couple of years and realize that they'd rather do a root canal, build up and crown and get 2,000 right now than drag it out over 2 years. And all those the fatigue rate of so they educate, they make friends with all these guys, and then within 1 or 2 years they all quit doing it. If the orthodontist is flipping their chairs every 15 minutes and you start doing ortho and you schedule a half hour for that same appointment, now you have twice the overhead. So if the orthodontist has 60% overhead and you're scheduling 30-minute chair time, I mean, it just doesn't even make, they all learn that, but then they become really great referral people.
Right.
The luckiest thing about you also is you get to live by the Arizona Cardinals, so you only have like a 5-minute drive to the game. I have like an hour drive to the game. But I want to get back to the millennials on this show, the under 30s.
Okay.
If the Cardinals, they'll tell you that, when what they want you to do, they say the games aren't won by fancy plays. It's 4 things. Did they block? Did they tackle? Did they pass? Did they catch the pass? That's the 4 basics. When you look at Crown and Bridge, the thing that's confusing, the biggest complaints about millennials when they go to these conventions, that all the Crown and Bridge courses, they're always full mouth rehab. But when you go to the labs, 95% of all the crowns are sent in one at a time. So
Yep.
go over a single unit crown on a 6-year molar. What's the block, tackle, pass, reception that these kids should kind of focus on? And they're probably also wondering, do you do this new, are you using zirconium, or using Empress, or there's so many materials. So go just review a simple 6-year molar crown.
For me, I guess the first piece of the puzzle is you do need to know what material you're planning on using for that because your prep design is going to be driven by your material. I will tell you in my practice, I told you I still do all gold. I do full contour zirconia. I do a full contour lithium disilicate or EMAX. And every once in a blue moon, I still do a PFM. I would tell you if it's a first molar, odds are I'm going to be doing lithium disilicate or EMAX. Where I use zirconia and full gold classically is on second molars or patients with high occlusal risk. But you need to know what material you're using. And in the world specifically of EMAX, you need to know whether you're planning to bond or cement, because that's going to drive your prep. So the first rule is prep the tooth appropriately for the clinical procedure, the material, and the cementation process. Then prepping a tooth, for me, is about be efficient, know what burrs you want to use, and create a burr system so that you can really go, okay, here's my burr for my occlusal depth cuts. Here's my burr for my occlusal reduction. Here's my burr to do all my axial walls and my margins, so that you can cut the same prep consistently all the time, and you're not dinking around wasting time trying to find the right burr. Third piece of that puzzle is impressions. Probably one of the things we do the worst in dentistry is take a really good quality impression. We blame it all the time on the impression material or the tray. It's about tissue management. I'm personally still a 2-cord dentist, so I prep equigingivally. If I'm planning to go sub-G, place a size 0 cord, drop my margin, then place a size 1 cord. And I'm a huge fan of retraction paste, not for retraction, but for vasoconstriction. But you need a really good quality impression with flash, so 1 millimeter of material that goes past the margin. And then, honestly, after that, it's you're home free. You know what? If you've prepped the tooth appropriately with enough reduction for the material and the cementation technique, if your margins are appropriate for that material, you've taken a good quality impression, you're going to get something back from the lab where your seat appointment is easy and doesn't take a lot of time, and your contacts are good. And I guess the last piece of that, Howard, is I think 97% of us let our assistants do our provisionals or temporaries. Make sure that your assistant knows that a temporary's got to have interproximal contacts. Otherwise, you're going to spend a ton of time adjusting the crown when it comes back. And your temporaries have got to have occlusal contacts, or you're going to spend a ton of time adjusting when the crown comes back. And they got to seal the margins, or the patient's going to call and complain about sensitivity. So I don't do mine either. My assistant does them, but my assistant knows what the expectations are for how a provisional fits that supports us having an easy crown seat appointment.
If you make the temporary with your assistant, you can make it so much faster, but that you'll never have a reduction coping, because you figure out all those things when you're making the temporary. You go to adjust a temporary and you're like, I just adjusted clear through my temporary. So exactly. I mean, you can work.
Well, and using depth cutters too. That's one of the things. I think a lot of dentists come out of dental school and they think dropping depth cuts was something they just made us do in dental school to torture us. That it actually really is important that you know that you get the right reduction. And that's a measurement device, is to use a depth cutting burr.
Yeah. So what impression material do you use?
I use Flexitime Extreme from Kulzer.
Flexitime Extreme from Kulzer.
Yep.
This is Dentistry Uncensored, so I want to ask you some controversial questions. A lot of these kids walk out of school $350,000. The 2 schools in our state are both private schools. They're very expensive. These kids are coming out $350,000, $500,000 debt, and there's so much pressure on them that to really be a good dentist, they got to drop $150,000 on a CAD cam, $100,000 laser, $100,000 CBCT, and they're saying, man, I could come out of school, make 3 purchases, and double my student loan debt. So if a 25-year-old kid said to you, if I want to be a good, great dentist like Lee Ann Brady, do I need a CAD cam machine?
Well, I guess the answer to that would be no, since I don't own one currently in my dental practice.
I guess that kind of sums it up.
Yeah, I mean, honestly, I love the technology, and I taught the technology for years, as many people know. And I don't own one in my clinical practice because I just bought my practice 5 years ago. I was an associate for 1 year before that. And I have a really large six-figure note on my dental practice, and investing another large six-figure number to buy in-office milling technology doesn't make any fiscal sense in my practice right now. 5 years from now, if you ask me that question, it's possible I will own CAD/CAM technology and milling technology because the numbers will work. I learned a lot of years ago that practicing dentistry always has to be 51% healthcare and 49% business. And those numbers can't get skewed. But they do have to be 49% business. I have to be a good steward of my business decisions, which always means my financial decisions. If you put yourself in fiscal hot water and you owe a ton of money and you're stressed about how you're going to pay it back, it is going to influence your clinical decisions, whether you think it is or not.
Yeah, and your stomach lining and your stress, which could lead to drinking and fighting with your spouse and
all sorts of things. Exactly. Yeah. So, be a good steward of your finances because it makes every other part of your professional life and your personal life easier. And, maybe this is part of the wisdom of doing this a long time and getting a little older. I'm clear that I will have the opportunity to buy that cool stuff in a few years in a way that it will be less stressful. So I'm not in a super big rush to do that.
Okay, same question about oral scanner for impression. You told us your impression material. What about oral scanning?
I do not have an oral scanner in my office, and part of that is I keep waiting for the technology to get even more mobile. So I think the technology, as far as the quality of the image and the scanners, is good. I don't necessarily like the size of the camera you have to hold in your hand, and especially this is maybe a gender discrimination piece, but if you have small hands, holding some of those cameras can be really challenging. But the other piece of it is just the device and the computer. I'm waiting for somebody to come out with one that literally you just throw the software on your computers in your office, and all you have to do is move it from room to room, plug it in with a USB. You don't have this big thing you have to wheel around or move around. But I love the technology, and probably my favorite thing about the technology is it makes us better dentists. You cannot look at your preps on that computer screen and not be motivated to do better.
Absolutely. Same question, lasers.
I do have a laser in my office. So I have a CO2 laser in my office. I grew up on electrosurge. And so, right?
I can still smell it.
Exactly. And, I would not use that technology today. And when I started to do some research into lasers, for me personally, moving to a laser and going diode, which is in some ways a glorified electrosurge because you're not most of the time cutting with laser energy, you're still cutting with heat. I said I might as well go all the way to really using a laser where I'm going to have less patient post-op discomfort, faster healing times. I've got the advantages of actually using a laser. So I do use that in my office as an adjunct for my restorative dentistry. I don't do a lot of surgery for its own sake.
And which laser, which brand did you get?
I actually have a DECA laser, a CO2. I'm not even sure, honestly, Howard, what their position is in selling it in the States anymore these days.
Yeah, that's true. So a lot of some of these kids, they come out with $350,000-$500,000 in debt, and they want to be an associate for a long time. What would you say to a kid who's thinking, I want to start my own practice like you, versus being an associate? What do you think they should wrap their mind around?
Well, I would tell you that I do think there's some advantages when you first get out of dental school to find an opportunity that lets you just be a dentist for a while. I hear lots of phrases that refer to that, but you honestly just need to be someplace where you don't have somebody looking over your shoulder. You need to learn how to do an MO in less than 4 hours. And right? You need to actually get used to being a dentist out in real clinical practice, not in a dental school setting. I know people who do that in 1 year residency programs. They get their speed up a little bit in their independence. Others who go into practices to just be associates where they know somebody else is worrying about the business, somebody else is driving them patients, and they get to just be a dentist for a year or two or whatever it takes them. And depending upon the associateship you get into, it's also an opportunity to learn to be a business owner. I have yet to meet a person who comes out of dental school who knows how to run a business. We're not taught that. We get the bare minimum from that perspective. And so being in somebody else's practice, be curious, ask questions. How do they hire and fire? How do they handle their payroll? What percentage of the overhead are clinical supplies and rent? It's an opportunity to learn those things without learning them where you actually have to learn them and make it work at the same time. So I think those are important pieces of the puzzle. And then you will also figure out for yourself what's the best fit for you. Lots and lots of the dentists that I know could not work in any other way than owning their own private practice. They need control. They need autonomy. And on the other token, I know lots of dentists who want to just be able to show up for work in the morning, be with their patients, treat the clinical situations, and go home at 5 o'clock and not worry about, there's a leak in the supply room closet where the compressor connects, and they're raising my rent next year, and all of those pieces. So part of it is figuring out what you want, but the other piece of that is recognizing that in a well-run dental practice, you should be being paid not only as the dentist who produces dentistry, but you should be being paid or compensated for the management and the leadership. So that, yes, you are spending more time than the person who doesn't own the practice, but you're also getting compensated for that investment of time. And figuring that out takes a couple years for most people.
I want to ask you another. I only got you for you're on your lunch break. I only got you for 6 more minutes. I got to squeeze in a bunch of questions. Since you're a woman, they're always saying that since it went from mostly all men to now half the graduating class women, you always hear a bunch of men saying how that's going to change everything. Maybe they won't work as long. They're going to stay home and have kids. Blah 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 blah. Do you think the half the class that are women are going to be any different than the half the class that's men? As far as like a lot of them say things like, well, the women, they just want a job. They're gonna, that's what's going to fuel corporate. But then when I look at corporate, their number one problem is employee turnover. I mean, some of these chains can't keep their average dentist a year, and if they can keep a dentist 2 years, it's considered a miracle. So are women dentists more likely to do anything different than their male colleagues?
The truth is my gut answer is going to be no, I don't think so. I just spent the weekend with 12 other women dentists at our women's program down at the Pankey Institute. And every woman in that room was a practice owner or a future practice owner, because that's their goal. Because I think the things that bring us to dentistry are the same regardless of our gender. We love people. We're half science and half art. We want to be in a healthcare profession, and we want to be autonomous. We like that environment of being in control of our own world, regardless of whether we're men or women. And so that's going to lead the majority of dentists to being private practice owners, or at least in a position of control or leadership in the practice they work for. And I just think it's so funny how I hear lots of people say, well, we're going to need a whole lot more dentists because women are only going to want to work 3 days a week. Most of the men dentists I know have always aspired to only work 3 days a week. That's a measure of success, is to only be able to work 3 days a week. So honestly, when I talk to dentists all over the country, I don't hear differences. I think there's different logistics to work out. And I think that we may come up with a whole bunch of new practice models and paradigms that are still private practice based, but that maybe fit differently for this whole new generation, the whole new generation, men and women. They see their worlds differently than we did, Howard. They see how work fits with their family differently than we did 29 and 30 years ago. But I don't think it's as much of a gender issue as it is just a generational issue.
Yeah, I mean, all my memories of my dad. If I wanted to see my dad, I had to go to Sonic Drive-In.
Yeah.
He was there from morning to night, and I thought nothing wrong with it because that's just all we knew. And you got to see your dad and eat a cheeseburger at the same time. How cool is that? Last question, because I know you're on lunch break and you're so amazing to come on the show. Um, how can these young kids? I mean, when I think of you, I think of leadership. I mean, you've been a leader in dentistry for 30 years. How can they speed up, fast forward, learn to be a leader?
You know what? Honestly, I think you put yourself in the path of leadership. So be active in our profession, be active in continuing education, be active in your local dental society, be active on Dentaltown. Pick a community in dentistry. And there's lots of communities. There are real ones and there are virtual ones. And put yourself in that path. Speak your mind. Share your opinions, and get to know our profession. I think one of the saddest things about our profession is how many people go into their little practice all by themselves every day, and they don't interact with the rest of the profession. And you know what? Dentistry is darn hard work, Howard. Okay, I know nobody else outside of being a dentist understands that, but it's darn hard work. And one of the most important things you can do is sit with another dentist so that you could celebrate that veneer case and somebody else is going to get it and not think you're a weird geek. But you could also talk about the 5 really stressful things that happened in my practice today, and nobody's sitting there going, oh, woe is me, you poor dentist, you, right? That they actually get it. So be involved would be my 2 cents.
But one last thing that's so different about you versus the other 99% is they're afraid to say anything. I mean, they go to these meetings, they don't talk. They get on Dental Town, they don't want to post. I mean, the lurkers are off the charts compared to the posters. They're
Right.
all afraid to say anything. Like when you give up and lecture, they couldn't do it because someone might raise their hand and say, "Hey, I disagree with that. I think the dish should be in the other room next to the refrigerator." They're just what how did you not have that fear?
Oh, I did have that fear. And I think all of us have that fear. And one of the things I embraced a long time ago about dentistry is there is no one way to do it. And there's no one right material, and there's no one right technique, and there's no one right practice model. That there's as many different possibilities, and they're all excellent choices. They're just different choices. And it's funny for me that in a profession full of people who want to be individuals, that you're right, that we all get together and then we don't want to be that individual, right? We don't want to have that individual voice. For me, it's like, hey, okay, you know what? I take physical impressions. I use goo. Is that for everybody? Nope, not for everybody. Does it work for me right now? Works for me right now. Is it possible it won't work for me in a year or 2 years or 5 years? Possible it won't work for me. You use a scanner. Awesome. I think that's phenomenal, right? So as a profession, if we could embrace the fact that there's a lot of different ways to do it that all come out of our commitment to our patients, that I've yet to ever meet a dentist ever who sat in the parking lot before he got out of his car to go into work and said, let me see how many people I can screw up today. Right? We don't do it. We all go in with the best intention to be the best we can be and to help our patients. And our expression of what that looks like is as individual as we are, that patient is, and our offices are. And so if we could all give each other a little space that we all have the best intentions and we can be different, then I think those younger folks would feel more comfortable speaking up.
Last question. You've had a really big year. You launched restorativenation.com, which is huge and amazing. But you also took over you're now back at Pankey. I was wondering, is that because you went to University of Florida and is that your way of just hanging out more, spending more time in Florida, or what? Tell us your Pankey move.
Yeah, I was missing the beach, Howard. No, actually, you know what? I love Arizona, and I am not leaving Arizona. I'm not selling my practice. This has been a big year with lots of changes. There's a way for me. This is about going home. I actually didn't go down to Pankey as a student until I'd been out of dental school about 13 or 14 years. So even though I went to Florida, I didn't realize I had that resource right in my own state. I went to the Pankey Institute after actually giving up practicing dentistry because I got burnt out and I hated it, and I quit for 3 years and got forced back in because I had to earn a living, and happened to end up meeting a dentist who'd been down there, and it changed my life. It really is the place that taught me I can love practicing dentistry, that I get to choose. All the things we talked about today. I wouldn't be who I am as a dentist, as a spouse, as a parent, or as an educator if it hadn't been for the Pankey Institute. They also gave me my opportunity to teach for the very first time in my career. And so they approached me this year and asked me if I would consider stepping back in, because I was a full-time employee there, as you know, for 4 years in the early 2000s, and take over being director of education. And, for me to be able to help them grow and move powerfully into the future and be there for other dentists so they can get what I got, and give back for the gifts they've given me, it kind of was a no-brainer but to say yes.
You are an amazing person, an amazing leader. You left dentistry better than you found it. You're truly one of dentistry's 1,000 points of life. I want to thank you so much for coming on and spending an hour with my homies today. This has just been an amazing, amazing podcast.
Well, thank you. I'm super honored to be on the podcast, and sorry it took me so long to make it happen.
Oh, well, hey, I would have waited 20 years to get you on the show. All right, have a rocking hot day, Lee Ann. Thank you so much for all that you've done for dentistry.
Thank you, Howard. Thanks for having me.